So self-harm, we're aiming to improve community services for self-harm. This is what I'll kind of talk about over the next kind of 40 or 50 minutes. So I'll start with a bit of context, why self-harm is important, the extent of the problem. That's going to be familiar to all of you, I guess. I'll then move on to what the actual current NHS England kind of programme is about and what we're all doing here. I'll move on to thinking about, because when we develop our service offer or develop our services for self-harm, thinking about the different settings where we might want to focus our efforts and saying a little bit about those. Some settings which I think are probably quite well covered by current provision, other settings which are perhaps less well covered. I'll then move on to some of the evidence, just a quick whiz through some of the evidence about what works and what perhaps works less well for self-harm. And then, because everyone keeps asking us about it, just a little bit about self-harm and COVID-19. So I hope that's okay. We'll make the slides available afterwards, as well as obviously the recording available for you to share. Let's start with a bit of context. Now, I'd like to start with a little bit of historical context, because I've been working in self-harm and been interested in self-harm for almost 3 decades, so about 25 years. And one of the things that often comes up is how things developed over that time. And last year it was quite a nice kind of, if you like, editorial exchange, so kind of discussion in print between this is the guy, Alan House, Professor of Psychiatry in Leeds, who kind of trained me. So when I came into research 25 years ago, he was my boss. And he published an editorial saying, well, things have really not improved at all. I countered actually by saying I think things have, we've made significant strides in self-harm service provision, I think, in the time that I've been in the area. But actually, there's still a long way to go, and that's, if you like, where we come in. I think we have made great progress. People are getting a better deal, but still we could do a whole lot better and develop our services. And why I think this is particularly exciting, this programme, it's a real opportunity for us to improve things for service users, for patients who are self-harmed. And there's a lot of interest, a lot of kind of policy priority at the moment, lots of kind of documents, policy documents, guidance coming out. It's a real priority and a real opportunity to improve things. Now, self-harm, we tend to use the inclusive definition and a kind of nice definition when we're talking about self-harm. So self-poisoning, self-poisoning is the most common method in hospital settings. Self-injury, so self-cutting, is more common in community settings, but we have this kind of catch-all, so it's irrespective of apparent motivation or medical seriousness. So in general, when we're talking about self-harm, we're not trying to separate out attempted suicide or non-suicidal self-injury. We're treating it as a whole. That's not to say that everyone needs the same treatment. Of course, treatment needs to be individualized, but it's a recognition that even people who are labeled as non-suicidal have a greater risk of suicide and adverse outcomes. And often, it's not easy to kind of separate out exactly what someone's motivation or intent is. So we've got this inclusive definition, really, so people aren't, if you like, filtered out of treatment. But self-harm is really common. So just in terms of hospital presentations, over 200,000 episodes in England, 150,000 people. So one of the commonest reasons for hospital presentations. One of the things that often comes up is, when you talk about self-harm, people think, self-harm, that's a problem with young people, isn't it? And I think one of the really important messages is it occurs across the lifespan, so middle-aged men, middle-aged, women in middle age, in older adults as well. This was a paper we published a couple of years ago, looking at older people in primary care who had self-harmed. And I think that's an important message in itself. Older people self-harm too, but for older people, I think the risk of suicide, older people who self-harm are at greatly increased risk of suicide. Everyone who self-harms is at increased risk. So in the year after someone presents to hospital of any age, they're at between 30 to 50 times higher risk of dying by suicide. But for older adults, that's even more marked. And in this study, only about 1 in 10 people were referred to mental health services. So group who are at high risk, not really being referred to statutory services. But of course, the different groups may be having different targets for intervention. So for older adults, social isolation, bereavement, physical illness, and psychiatric, psychological disorder might be potential targets for intervention. But the important messages there occurs across the lifespan, and of course, the link, the association with suicide. So common problem, potentially serious consequences. How do we do in terms of current management? I think this Samaritans report from last year summarised things really quite well. It was called Pushed from Pillar to Post. And I think, it summarises rather well the experience of some service users, some patients where, they've hurt themselves, they've self-harmed, they're trying to get help, but they're actually kind of going from one service to another, from primary care to community mental health, trying to get referred into talking therapies, not being accepted or being accepted, and this idea of kind of fragmented services. So this, the current programme, that's what it's all about. It's to kind of try and address that fragmentation, trying to improve the care people get after self-harm. So the current programme, so there's been, I think, some discussion about, where does this all sit now? Where does this current programme, the self-harm bit of work actually sit? So it's actually within, the long-term plan and within the community mental health framework. So as part of the kind of transformation of community mental health services, NHS England improvement have put in lots of money. So it's about £1 billion. And really the essence of that, many of you have been very much involved in that transformation. The essence of that really is, I suppose, integration between primary and community mental health care. And the idea is, seamless service. So someone pitches up and they have a seamless service with different aspects of care kind of co-located. And they might be co-located physically, they might be co-located virtually, but the whole thing is about integration and avoiding, if you like, barriers to referral and accessing treatment. So that's a major part of the investment. Now, people have said, well, what's the money that's specifically allocated to self-harm? And the message from NHS England, the message from us really is, if you like, there's no additional funding for this work. It's really part of the community transformation work. So many of you are kind of community transformation leads or involved in that process, and really this is part of that. And the ask here from NHS England and ourselves is really thinking about how you develop a plan to improve community services for self-harm, and then kind of obviously implementing that. So really kind of exciting time from our point of view. So what are we doing in all of this? NHS England have asked us to help support all areas with evidence. So we're the experts on evidence. We know about the latest research. We're responsible for producing some of the research. So we're going to support you with that. We can help you with what's evidence-based and what isn't. We can comment on your plans, as you develop them. In the first wave of this programme, so this is the, if you like, the second wave, we got comments to the plans and formally commented on them. This time, we're happy to help you develop them. There's no requirement for us to kind of give you 2 rounds of feedback, so we won't be doing that, but very happy to advise on those. We'll talk about, happy to talk to you about how you implement things, how you measure stuff. I'll come on to measurement in a second. So we'll do that by having site visits. In the olden days, as I said, those would be face-to-face. They're virtual now. This is one of them. So we'll hear from you, you'll hear from us, and we'll hopefully that will help in developing your thinking about what you do about self-harm. You'll get regular email contact from Debbie and the team, just checking in with you. Caroline and Leah every month, every 6 weeks, will run clinics. So that's open to everyone, where people might bring issues, they might bring kind of dilemmas, and kind of we'll think about those together in a kind of interactive setting. One of the key things here is shared learning. So we had 12 early implementer sites that have been at this for a while. Some of them have developed really good plans for self-harm, but actually, you know, about 30 sites in this second wave, and a lot of this is about shared learning. So thinking about what other sites are doing, pinching from each other, stealing ideas in this context is really good. Colleagues at the National Collaborating Centre for Mental Health always kind of make that point, that this is about shared learning. And there's a website as well. So the website is here. All these slides will have links on them, so you'll be able to kind of click on them, and hopefully that will take you through to the link. So here's our website, and we've got kind of this continuously updated, so various things. So, you know, if you want to know about kind of guidance, if you want to know about risk assessment scales, you can click on those, and that will take you through to some of our research. So this is continuously updated, so do take a look at it. If there's stuff missing, if there's stuff wrong, if there's stuff, you know, you can think that might be helpful to people, do let us know. Ian is our lead on that, and we can incorporate that. So that's a live resource, the website, which I think is really good. So key things for you to think about as you're developing a plan. One of course is implementation. So how are you going to implement? And you need a methodology, I think, to implement. You know, sometimes in services we just kind of implement things without thinking about how we're implementing them. But you know, implementation methodologies like quality improvement and other methodologies, I think, are really helpful if we're thinking about, you know, how we formally introduce things. But the other thing, of course, is measuring. So making sure whatever it is we're up to has some kind of is doing some kind of good. Obviously, there, you know, we're talking about self-harm here, so one of the crucial things will be data on self-harm. So, you know, outcome measures. You might be thinking about hospital presentations. You might be thinking about admissions. You might be thinking about, you know, the community incidents. Obviously, those are important measures. They're actually quite difficult. So Caroline's been spending many years with our local self-harm monitoring project, and will tell you how difficult some of these things are to code. You know, sometimes self-harm isn't well recorded, isn't well kind of delineated in databases. So this is absolutely, we'd like you to record self-harm, but it is quite a challenge thinking about how you record self-harm. But the other thing are, you know, if you like, process type measures. So it's not just about outcome measures, it's process measures. So, you know, thinking about to what extent your local service, your local area implements guidelines, implements quality standards. Thinking about, you know, getting feedback direct feedback from service users after they've used the services, or activity levels. Also, you know, important outcome measures, important in terms of measuring what you do. So measuring is really important. So some of you might be a little bit daunted at this point, thinking, wow, we've got to develop our self-harm services. Goodness me, you know, how are we going to do that? I mean, of course, you're not starting from scratch. There's loads of brilliant work going on in areas already, and we heard from some of them recently. So we've been doing a few of these meetings. So, you know, there's lots of activity going on, and there'll be lots of activity going on in your areas too. And the other thing is, obviously, you're the second wave, so you can learn from some of the earlier implemented sites. So on the website there, what we've tended to do is turn some of the early implemented sites plans into these infographics, which people seem to like. So this one's from Frimley. Their one was about, you know, brief psychological intervention after self-harm, so timely access, you know, 4-session intervention, and also thinking about how they'll measure impact. Here's the one from Somerset. This was about developing digital resources, which I know a lot of areas are doing, and again, thinking about how they're going to measure impact. So one thing to kind of reassure you is, yeah, you're the second wave. The early implementer sites have been at this. There's some of the summaries of their work on the website, and you can learn from them. But this work, the self-harm community services work, also sits in the context of other work. And again, it's about linking with other people in your areas, in your organisation. So this is a sequence. So a sequence, for those of you who aren't familiar with them, is a like, if you like, a health service kind of target, which comes with a little bit of extra funding. So services are encouraged to kind of meet the targets, and they get a little bit of extra funding. And we've been trying to get one around self-harm for many years, and I'm really delighted to say that from April of this year, there will be a sequin on self-harm, and really that's aimed at improving the psychosocial assessments after self-harm, improving the proportion of people who get an assessment, improving the quality of those assessments. So the sequin is going to be out there. So a lot of you may be involved in discussions locally around how services are going to meet that sequin. If you're not, though, I think one of the messages from today's talk is link with those people, because although the sequin is really about hospital services, if you like, it's the mirror image of the community self-harm programme. Again, one of the other bits of existing work that's going on that some of you are directly involved in, but some of you may need to make contacts with the people locally who are leading this work, is the quality improvement for suicide prevention programme, also funded by NHS England, where basically now all countries have been covered in different kind of waves over the last 4 years. And again, what we're doing is we're helping people to think about how they implement evidence-based suicide prevention in 3 areas. So it's mental health patients, people who self-harm, and men in midlife, particularly in primary care. So many of you involved in that programme. Those of you on, would link with your suicide prevention programme leads, because actually one of the priority areas is self-harm, and there's lots of great work going on around assessment, around interventions, around psychology input into emergency departments. So linking in locally and with the QI programmes more widely, I think could really help. So linking in with sequencing, linking in with suicide prevention programme leads. The other overarching, I think one of the overarching kind of elements of the programme, and something we'd strongly encourage, is just making sure that you've got adequate service user, patient and carer involvement in any plans that you make. I think a few of you were at the kick-off event for this programme that we had towards the end of last year, and that comes across. So Dr. M was the service user contributor at that, and when you hear from someone that's experienced services, been through it, that has so much impact. They've got so much kind of insight to offer, and it has a real I think benefit in terms of kind of service development when you're asking, in the old world about commissioners, but in the new world about who's making the decision about services. If we can get service users there as part of the development process, I think that's so helpful, and there's evidence that it improves outcomes too. Okay, so I've talked a little bit about the general context of the current programme, so hopefully everyone's a little bit clearer about where this piece of work sits. I want to move on now to settings. So many of you will have seen me present this before. This is the iceberg model of suicidal behaviour. So, this idea that suicide is if you like, at the top of the iceberg and most serious consequence, but under that, you've got self-harm, which presents to maybe hospital services, but then under the waterline, almost kind of hidden, is this bigger iceberg, if you like, the iceberg below the water of self-harm in the community. And I think one of the ideas behind this programme, one of the things you need to be thinking about, is how you provide something at each level of the iceberg. So people under community mental health services who maybe aren't getting access to psychological interventions, people who present in crisis but might just be sent home from an emergency department without any follow-up, but then also people who are presenting to their general practitioners, or people who don't come to the attention of services. So thinking about what the offer might be in each of these areas, and obviously making sure that different groups are covered. So young people, older adults, we've already talked about, people from LGBTQ plus communities, but also people from ethnic minority groups, and making sure, you know, you've got coverage, and different areas have, you know, different makeup of catchment populations, etc. But yeah, that's important. So this is some work we did specifically focused on ethnicity and self-harm to young people in Manchester. This is work led by my colleague Bushra Farouk. And the big story really is, I mean, young people from ethnic minority groups tended to live in more deprived areas compared with their white counterparts. But the big thing was access to treatment. So everyone should get a proper assessment after self-harm. But in this study, we found that young people from ethnic minorities were less likely to get a psychosocial assessment than white young people, and less likely to get mental health aftercare. So this access to treatment, I think, is really important, and something you need to bear in mind when you're developing your plans. So for me, one of the big kind of opportunities here is thinking about self-harm in primary care, because I think traditionally that's a setting, an area that's been quite kind of neglected. And because this is about, if you like, communities, this is about community self-harm, self-harm that occurs in the community, I think self-harm is a key area that we could intervene. So this is a study led by my colleague Matthew Carr, big primary care database, and looks at self-harm by deprivation. What we see here is people split in order of how deprived the areas are they live in, how socioeconomically deprived. And what we see is people who live in the most deprived areas, the fifth most deprived areas, have the highest incidence of self-harm. So we know that. We know deprivation is associated with mental health, ill health, it's associated with suicide, it's associated with self-harm. So that's perhaps not surprising. So a greater burden of self-harm in deprived areas. But what's quite interesting is when you look at then access to kind of aftercare and referrals to mental health services. These are referrals to mental health services. And what you see is, although people who live in the most deprived areas have the greatest incidence of suicide, they're the least likely to be referred for mental health follow-up, mental health aftercare. And I know public health colleagues, some public health colleagues are on the call, you know, a kind of good example of the inverse care law, where basically people at the most need are getting the least access to care. So the inverse care law. So that's something really to kind of think about. In this big study, I mean, there were other things as well. Quite a lot of people receiving medication, you know, not very many people perhaps being referred to mental health services. So thinking about the balance between medication and referral in primary care, especially for self-harm, and thinking about inequity and access. What can we do about self-harm in general practice? There's not a whole lot of research here. This was a systematic review done by our colleague Faraz Mughal, who's an academic GP working at Keele. You know, thinking about some of the things where, you know, we might help. We might improve the management of self-harm. Obviously, training comes up, service provision, clinical guidelines involving people, but also some of the barriers which will be very familiar to many of you. You know, service provision, not having the services to refer into, thinking about kind of assessments, local factors, referral thresholds, that kind of thing. So very familiar. Encourage you to click on the link and take a look at that, because I think general practice primary care, big opportunity for thinking about what we do and how we might improve. Other areas that are really important, of course, are educational settings. So this program itself is if you like, 18 plus. So the self-harm community services is 18 plus. You'll have other work going on locally in relation to younger people's self-harm, and we'd encourage you all to kind of join it up. For some areas, of course, you know, universities, many areas have universities in their catchment. It's a hot topic, self-harm, suicide prevention within university areas, and there are existing resources out there. But again, thinking about working with educational settings to how we might best help people who self-harm. And it's not, of course, just about statutory services. It's about the third sector, voluntary services. Of course, we're familiar with many of them as providing information, etc. But perhaps the two best known third sector providers in this area, Harmless and the Samaritans, and actually being actively involved in service provision. So we heard from colleagues in Nottingham yesterday about Harmless's work with direct service provision to support mental health services, to support statutory services, and Samaritans as well in many areas of the country, and locally in the Northwest. Samaritans very happy to help us with providing some follow-up for people who haven't had an assessment or left before being seen. So really important that you involve third sector colleagues as well. And of course, the other setting that's really important for self-harm is the home setting. So thinking about involving families, how we best involve families, I think is really important. So there's some resources there. One of the things that often comes up though is the whole issue of confidentiality, and not being able to share information. I mean, this is there was confidentiality, there's a consensus statement on confidentiality published a few years ago, and it's recently been updated. This is the Zero Suicide Alliance, if you like, kind of further guidance and kind of implementation guide. And the idea here is services mustn't, if you like, have a default position of kind of confidentiality or hiding behind confidentiality, because we know sharing information, obviously with service users, full consent, can help outcomes. So this is about how we change the default position when a service user comes into service. So well, we know involving families, we know involving significant others will improve the care that areas will be able to provide. So we want to involve them. Is that okay with you? Obviously there will be instances where that might be unhelpful. The person might not agree, and we will, that needs to be respected. But information sharing can also be very helpful. So please do look at that guidance. Okay, so we've talked a little bit about the different settings, making sure that you have coverage of perhaps underrepresented groups. So let's move on now to the evidence, and in some senses we've got a bit of a kind of head start with the evidence in self-harm, in that we've got NICE guidelines. So I've been involved in NICE guidelines for a very long time, and it's always striking that the first NICE guideline for self-harm was 2004. Previous guidelines even older than that. I remember guidance from kind of the 1980s as well. But there's been the guidance in 2004, the updated the longer term management guidance in 2011, the quality standards in 2013, which in some senses are a kind of summary of the most important bits of the guidance. And of course, many of you will know that we're currently updating the self-harm guidance into one. So these two are going to be kind of amalgamated. You can still comment, so register as a stakeholder and comment. The consultation period ends on the 1st of March, so encourage you strongly to contribute to that guideline. But the guidelines, if you like, summarize the evidence, so they're a really good starting point when we're thinking about what we might want to do in individual areas. The other thing that comes up again and again is evidence-based training. What training has the best evidence base, and there isn't a huge amount of if you like, outcome data on the outcomes of good quality training versus not. But we did some work along with Health Education England 2 or 3 years ago now, thinking about what the key competencies might be for staff. Working with adults and older adults, there's another competence framework for kids. There's another competence framework for non-specialist and kind of, if you like, public health type settings. And what this does really is summarize the key skills, knowledge, and attitudes that we might expect staff to have. So basically, if you click on the link, you end up with a kind of map. You click on different bits of the map, and it comes up with a list of, if you like, key skills, key attitudes and bits of knowledge that we would expect staff to have. So basically, I know a lot of areas have developed their own training. Other areas are kind of commissioning external training, and our message really is, one of the things is you can use the competence frameworks to almost audit the training, look at gaps, look at things that you might want to kind of develop as aspects of your training. And there are a lot of kind of, you know, training resources out there as well. But many of you are familiar with the competence frameworks, but do take a look at those. So you've got the guidelines, you've got the competence frameworks. What about kind of, you know, if you like, the research evidence and what that tells you? One of the things I think that's really important is making sure that if someone's hurt themselves, they get an assessment. So certainly if they're presented to services, obviously it's very difficult if they're in the community and no one knows about the self-harm, but for those people who present to services, yeah, they deserve a proper assessment. And I suppose, the thing that's still surprising to me is around half the time still, someone will present to services with self-harm and they won't get assessed. So, you know, we could really do something there to improve the levels of assessment, because just that assessment, research suggests, can reduce the risk of repeat self-harm by 40%. How does it do that? So this is some really nice qualitative work from Liam Quinlivan, who's on the team but unfortunately can't be here today. Just thinking about, you know, what service users said helped, and you know, this is perhaps what we'd expect, you know, humanising care, something that's collaborative, space and time to talk, compassion and reassurance. So it's something there about, you know, the quality of the interaction, the listening there and then, but it's also about plugging people into aftercare, so people receiving help after they've had, you know, this proper assessment. So thinking about how we improve assessment. But the other thing that's really important is what happens afterwards. So what happens after the assessment? And one of the things we know is that talking treatments are an important part of aftercare. There's a nice busy slide, but all I want you to look at is that black diamond there. This is a forest plot, so it just summarises lots of different research, lots of different trials that have looked at people who self-harmed, have received a psychological therapy. And the bottom line is, if you get a talking treatment after self-harm, you're between 30 and 40% less likely to repeat. So providing some kind of aftercare, we know very few areas in the country provide routine aftercare through psychological intervention for self-harm. But if we can do that, we can reduce repeat rates. One of the things I'm always asked is, well, okay, what talking treatment should we provide? Here's a meta-analysis by some of my colleagues in Australia. Basically, they looked at this and they didn't see any great differences by type, intensity, or whether the therapy was delivered at home or in the hospital. Obviously, there's issues of access if you're delivering people therapy at home. Also, you know, now of course online and remote consultations as well. So the message from, anyway, this study is, you know, the exact flavour of therapy doesn't matter, as long as you're providing some kind of evidence-based treatment in terms of a talking treatment. That's probably a really good idea. But if you're going to provide it, I think you need to provide it very quickly. Why am I saying that? This is some data looking at how quickly people repeat after self-harm. So these are people who've repeated within a year of self-harm. And basically the message is that if people are going to repeat, they tend to repeat quickly. So in terms of the first 30 days, in first month, a third of people who are going to repeat within a year repeat within the first month. And it's even more stark than that, because 10% of people, 1 in 10 people who are going to repeat, will repeat within the first 5 days. So this idea that, you know, we're going to send them an outpatient appointment in 3 weeks' time, or we'll refer them for, you know, some kind of self-help that's going to start in a month, we're kind of wasting our time. If we're going to provide aftercare, if we're going to intervene, we need to do it quickly, and obviously that's a challenge. So if we're going to get in there, let's get in there quickly. Risk is something that those of you who work directly in mental health services know that all mental health services are obsessed with risk. In a lot of areas, you know, risk tools and risk scales are still in use. You know, after self-harm, to score people. What's the research evidence from there? Research evidence from ourselves and others. You know, some of the papers there behind the box. The positive predictive value is about 5%. What does that mean? That means is if I rate 100 people as at high risk, actually 5 of them will be at high risk. So 5 out of 100. In other words, I'm wrong 95% of the time. But that isn't the biggest problem with risk scales and the whole approach to risk assessment. It's all the people we rate as at low risk, because they're quite a large group, people being rated as at low risk on scales or other things. All the people who die, all the people who repeat self-harm in that low risk group get excluded. So that's the problem. If you're using risk scores to allocate treatment, you miss people and you exclude people. So we suggest not using risk tools and scales. Risk assessment isn't a checklist, and risk itself kind of isn't a score. What about the role of digital interventions? Obviously in the last 2 years we've all become much more familiar with these. It's interesting because researchers, even when they look at the same evidence base, come up with different conclusions. So this is looking at digital interventions for suicidal ideation and self-harm, and this group of researchers said, well, we need further research. This group of researchers from Sydney said, well, no, actually they're ready to be implemented and disseminated. What's our view? Our view is, I think, there have been times over the last 2 years where we've had no choice, where we've had to provide interventions and assessment remotely. I think for our view would be, there is some evidence base behind this, not just from suicide prevention, but from depression and other things. And hopefully going forward, what we'll be able to do is provide a choice. So for some people, it definitely wasn't for them, and I can just think of assessments that I've kind of seen over the years where the finer points, the finer kind of clinical details, you wouldn't be able to pick up over Zoom or Teams. You needed to be in the room. So I think definitely a role for face-to-face. But other people have told us, well, actually, it's been a lot easier to get to appointments. It's been a lot easier to attend. I've really liked it. It means that I haven't got to kind of deal with trying to find parking in the hospital. It means that I can just get in and see my therapist, and so choice, I think, going forward. But digital interventions, there is an evidence base and they can be helpful. Okay, what I'll do just in the last few minutes then is talk about the last 2 years and what's happened with self-harm and what we might do going forward. This, of course, is what we're all, it's difficult to remember back, isn't it, to the spring of April 2020. It's all been a bit of a blur, but remember what it was like right at the beginning. Everyone was worried that the indirect consequences of COVID-19 might be even greater than the direct consequences. And what do we know about the impact? Even fairly early on, I think we knew that it was having an impact on mental health. So this is a study from some colleagues in Manchester, and it's a repeated kind of survey, if you like. So looking at quite a large number of people, thousands of people, where they're looking at mental distress on a questionnaire. So it is self-report on a validated questionnaire, and basically during the early part of the pandemic, about a 10% increase in clinically significant mental distress in the population. How did that translate into self-harm? Well, it was interesting. So this is data from primary care. This is a graph from primary care, work led by my colleagues Sarah Steig and Matthew Carr. And we kind of summarised some of the findings kind of early on. And what we saw was a big fall off in help seeking for self-harm in the early part of the pandemic, from primary care, from secondary care. Of course, what I'm not saying is that might be a genuine reduction in self-harm incidents, although it's plausible it might be, because we know that suicide rates in many countries, including England, reduced in the early part of the pandemic. So contrary to expectations, they went down rather than increased, but self-harm presentations also decreased. What's that down to? It's probably more likely down to, remember those messages to kind of protect the NHS, people being also kind of frightened to seek healthcare back then, and also accessibility of services. So primary care being less accessible, mental health services being less accessible. But this fall off in care, I think, has been echoed to an extent in future work. And it isn't just the UK, so this is data from France, all of France, looking at hospital admissions now for self-harm. And basically what this is showing is for most age groups, the number of admissions fell in 2020 versus 2019. But there were exceptions. So for older adults, actually, in this study, the admissions for self-harm went up. And as in services here, I'm sure many of you, very familiar with this, that we did have fewer presentations, but for people who did present, there was greater acuity. So for self-harm, a greater proportion with kind of violent methods, more ITU admissions of death. So the acuity of those people who did present was higher, perhaps people presenting later. So if you like, help seeking for self-harm reduced in the early part of the pandemic. What about community self-harm? So this is the great study from UCL, from the social survey that they're doing. Tens of thousands of people participate in this, a repeated kind of survey, if you like. And actually, they've not got pre-pandemic data, but during the pandemic, reported self-harms remain fairly static, actually. This is a reminder, of course, so that in this graph it's split between those with a mental health diagnosis and no diagnosis, and people with a mental health diagnosis suffer more, have more self-harm than people without. So it's an important reminder there, but no actual changes in incidence. So a reduction in help seeking from mental health services from primary care, no reduction in reported self-harm in the community. The question is, where are people going? This is one study, not UK data. It's 21 helplines. So, if you like, was the slack being taken up by colleagues in the voluntary and third sector? This study suggests to an extent it was. So this showed that calls increased after the kind of COVID-19 outbreak. What's interesting, though, is when they looked at these calls in more detail, they weren't about self-harm or suicidal ideation. There were things like worries about finances or worries about the virus itself. But to an extent, the third sector kind of complementing, taking up some of the work that, some of that reduction in activity may have translated into increased activity in the third sector. But the evidence is quite mixed. So some services increased. Some services didn't see an increase. Other services saw an increase in kind of call duration. Actually, is one or two bits of research showing that. But important, I think, in terms of going forward involving voluntary sector colleagues. What's happened since? Well, this is data now, emergency department data on self-harm, produced by Caroline and colleagues. What you can see here is perhaps reductions in help seeking around the time of lockdowns. Otherwise, it is a bit up and down, but important to, I think, monitor going forward. And all of this, I think, may change. So, in terms of kind of the economic fallout from all of this, current worries are about, if you like, the cost of living squeeze, fuel prices increasing. They are likely to have impacts on mental health and, by extension, I think, on self-harm. So we must keep an eye on these things. So keeping an eye on things, I think, is really important. But also just remembering the evidence we've got. So, the evidence is still the evidence. The guidelines are still guidelines. The context, though, has changed. So this is some of the evidence around suicide prevention, but much of it applies to self-harm as well. That actually, we know about all these things being effective. So, thinking about alcohol use within communities, making sure that kids are back at school, financial help for people who are in financial difficulties, all of that was important during the pandemic, will be important afterwards, thinking about kind of media, thinking about the role of services and research. So the evidence is still the evidence. The challenge for all of us, I think, going forward, is how we apply that evidence in the context of the pandemic, and actually now in the context of hopefully recovery from the pandemic, but services still being stretched. So I've talked a little bit about context and the current programme. So hopefully it's given you a good idea of where this work sits, where your plans might sit. Talked a little bit about settings, so plans hopefully addressing different settings that will vary according to your local priorities, but also will address different groups. A bit about the evidence, the importance of assessment, the importance of psychological intervention, but perhaps not relying on things like risk assessment to allocate treatment, and then a little bit about self-harm and COVID-19 and how we move things going forward. And the last thing I always like to do is just acknowledge all the hardworking team back in Manchester, some of whom are obviously on this call, but many others are just kind of beavering away, working as we speak.